Welcome to AAA Dressings, Adhesion Absorption at a Fair Price. My name is Kathy Milne. I'm an advanced practice WOCN nurse, and I practice across the continuum. So I see patients in acute care, long-term care, outpatient, assisted living, and even make house calls to the truly homebound. So I see dressings used for a variety of different reasons all across the continuum. So today I want to discuss characteristics of wound dressings that really matter at the bedside and look at the lab data that supports absorption and adhesion qualities of the Halyard foam and gelling dressings. And I'm going to talk about some cost effectiveness in the clinical setting too. So when you think about AAA, what does that mean to you? So some people think, oh, it's a car company that's going to save you if your car is broken down. But most people think that is the best thing you've got. And I think AAA means you have a combination of different things that actually put together give you the best outcomes. So what is the ideal dressing? Well, from a wound's point of view, the wound doesn't want anything toxic, it doesn't want any foreign bodies, and in fact, there are allowable foreign bodies in dressings in the United States. These are all foreign bodies that may be a little piece of dust or dirt or maybe some protein from some animal matter, but it's all sterilized. But there's no such thing as the perfect dressing that actually is completely sterile without maybe a little bit of foreign protein in it. But ideally, we are more worried about the bacterial barrier there, and we should be thinking about the adhesive because we do know that medical adhesive-related skin injuries are one of the most unreported injuries in the healthcare setting. We also want a dressing that's not going to disturb that wound, and we want it to protect the tissue. And of course, we don't want our patients to talk about how painful it is. Now, what about the patient? They have a thought about what should be the ideal dressing, and this has been published. So, of course, they want something painless, like we do, and like the wound does, but they want that dressing to promote the fastest healing possible. And that's a very reasonable request because nobody wants that wound to be open as long as it is. And they want to get on with their life. And they see something physically on that wound, and that's what they think is going to heal that wound the fastest. Now, in reality, we have to control their blood sugar. We may have to offload. We may have to control edema. There are other things, but the patient sees the dressing, and to them that equates into faster wound healing time. They also want reduced hospitalization time, and we all want that also. But as we know, dressings do not keep patients in the hospital anymore. Maybe 15, 20 years ago they did, but not anymore because the insurance companies really control how long that patient is really in the hospital. But I think we all want a dressing that holds exudate, and especially those patients. They don't want their socks wet, they don't want their bed sheets wet, they don't want their chairs wet, they don't want their clothes wet. So they think holding exudate is one of the highest quality measures for them, and we certainly would agree with that. And in conjunction with that, exudate is they don't want any odors associated with their wound and their dressing. And of course, because we may be a little bit more immune, so to speak, or maybe certainly more tolerant or used to these odors that our wounds exude, our patients are not. And when they do have an odor, it really impacts their social ability, even amongst their family members. They start to get shunned, people, they don't want to go out, so it really reduces their ability to interact with other people. And they just really want to get back to a normal life. And we want them back to a normal life, right? So if we are going to think about an ideal dressing, we really should be looking at the dressing construction. And so my sister is a wonderful cook. I mean, she is terrific. And she can make a cake with eggs and sugar and flour and what else would you put in a cake? Maybe baking soda or baking powder, and mix it all up and make this beautiful, fluffy cake. I can have the same ingredients and at the same measurements, same weight, and I can mix it up and my cake's hard, flat, and kind of like rocks, right? So it's because there's a difference. I may put the eggs and the sugar first, and she will put all of her dry ingredients together first. So it's how you construct a dressing or a cake really matters in terms of how it's going to perform. So the microstructure determines the physical, mechanical, and fluid transport and handling properties of that fluid in that dressing. And we don't really think about how dressings are constructed, and we really should be thinking about that because it affects both adhesion and absorption. So let's talk about that first A. So adhesives. Adhesives can be either silicone or acrylic. And silicone foam dressings, we've been using them for years. We all know about them. They use medical grade silicone. So that's really isn't what really differentiates these dressings that all have silicone, but it's the tack, how sticky that is, and how it affects peel force. And we're going to talk about peel force in a few minutes here. But we know that when we take off the dressing, we're going to have some type of epidermal stripping and maybe epidermal-dermal separation, and hopefully not MRC. So when you look at this picture here, you can see those little petechiae. Well, guess what? That is from the peeling off of a silicone dressing, but it had a lot of tack. So acrylics are a little different than silicones. Silicones, again, are a type of material, medical grade, that when you put on the skin, they actually stay almost on the top, and the adhesion you get at the point of the first application stays consistent, where acrylic adhesives actually will go into the nooks and crannies of that epidermis, and it strengthens over time, which is why we don't like to use acrylic adhesives, because they do cause more epidermal stripping and have an increased peel force, and they hurt more. So that's why we like to have those silicone dressings. So let's talk about peel force. So when you peel up a dressing, you will actually lift that epidermis and hopefully that dermis. But if you have somebody who is older or has been on certain medications such as steroids, you will have a poor epidermal-dermal junction. So when you're younger, it's adhered like this, and when you get older, the epidermal-dermal junction almost lays right on top of each other because you've lost that rete peg. So when you peel something off, you can actually separate those layers and actually cause a MRC or other type of skin damage. Now here's a perfect example of an acrylic tape being pulled off of an arm. And you can see how that skin is literally lifted off. And that's what hurts, and those patients really don't like that. So what's the data? So when you start to look at how you compare dressings, and we should be comparing our dressings, and because our value analysis people are really looking at costs, and we need to be able to give them data about this silicone foam dressing does this, and these are the differences. And it's nice to say, oh, I'm going to put it on my hand, or I'm going to put it on my knee, or I'm going to test it on the patient. But if we really want to get good data for our value analysis committees, we really need to use bench data. And so peel strength is a very common way to compare how much tact is actually on that silicone and what kind of force that you need to take that dressing off. But it also helps you determine how that dressing is going to stay on the patient, because you want enough tack that's going to stay in place, but too much tack is going to hurt, not enough tack, that dressing is going to come off fairly easily. So let's compare what's out there. So product 1 and product 2 are two major brands. I'm not going to discuss them, but the third in blue is the Halyard brand. When you look at the peel strength, so product 1 has really good adhesion, product 2 doesn't have quite the adhesion that we all probably want, but it's still one of the top selling brands. And here's the Halyard dressing over on the right. If you look at the peel force, it has enough tack to stay in place, but not enough to cause pain. And shape also matters from a biomechanics perspective, because with adhesion, you need to have conformability. So you need to be able to put that dressing down and then have it adhere and then into those nooks and crannies. And I like to call it, and pardon my crassness here, is the poop chute. So if you don't get it into certain folds, especially down by the bottom of the anus, you're going to have any fecal effluent come up through any gap and contaminate that wound. So you need to have dressing that's going to be conformable and not only stretch with the patient, because these patients move up and down, and they also, if you have the dressing on a bony prominence or a joint that actually moves back and forth, that's extensibility. So you need to have that dressing be able to stretch too. So if you think about the data on conformability, again, product 1 and product 2, these leading brands, at a higher price than the Halyard, you're looking at things that are comparable. So you have actually fairly good extensibility with the Halyard product, and as far as deformation or conformability, you actually are equal to one of the most leading brands out there, again, at a fair price. So adhesion will impact the economics. If you look over on that slide on the left, this is one of the leading brands of dressings, and you can see the adhesion is not as good as we really would like it in this patient. And when dressings come off, it actually costs you more money. When you have good adhesion and you're not getting any fecal matter in the wound, it's staying in place, it's able to absorb the shear and the friction that the patients have when we turn them, reposition them, when their head of the bed is up and they slide on down, then we're in good shape. If you look on the right-hand side, you'll see that the silicone border in that Halyard dressing actually can conform to the wrinkles in this patient's buttocks, and because this patient has no tissue, so they've got a lot of tissue laxity. So it's able to stay in place. The adhesion can conform to those wrinkles. So I think when you see the Halyard dressing, you really want to feel the peel for yourself. For example, here I am peeling. You don't see a huge lift coming off. And I always inspect the dressing for epidermal cells to see if I'm actually peeling my own skin. And I'm not. I don't see anything here. But you should try it for yourself, and you'll see the difference. Okay, let's talk about that second A, and that's absorption, because that's really where we want our dressing to work well, and our patients want it to work well. So the question is, how much does your wound drain? Now, we don't really know, because the wound type and method of exudate measurement is very variable. So when you start looking at how the literature reports wound exudate, so it can be done by weight, like the weight of the dressing. It can be done by fluid collection, like we would have a negative pressure wound therapy, canisters. We can look at vapor pressure gradients. We can look at evaporimeters. We can look at pressure gradients. The thing is that there's no normal rate. So when you look and try to compare the amount of exudate a dressing can hold, you really need to find out what that dressing mechanism was done at the bench side. Because sometimes you're just comparing apples to oranges. But we do know that viscosity matters. So one of the things that we should be asking our representatives when they come to see us is, what kind of fluid did you use to test absorption? Because if you used just plain old saline that's not very viscous at all. And you might find that they've used something a lot more viscous that simulates more thicker exudate. So one of the things you really want to look for in the dressing itself is, let's look at the holes. And you want to be able to compare the holes in your dressing. Now, this is really nice because I've crinkled this thing up and now I have to uncrinkle it. And guess what? It uncrinkles really nice, which is a good thing to have. But you want to start looking at the holes and compare your holes and see how much exudate may go through these. And so the shape of the holes, the size of the holes can also affect how much drainage and how fast the drainage can be absorbed by the dressing. So what don't we know? Well, when you start looking at a lot of the bench data, we don't know how fluid lockability is measured because the testing's not standardized. Odor control, again, not standardized. The ability to protect the periwound skin, again, not standardized. And then pain, well, that's really subjective to the patient. So we can't really measure that in a laboratory setting. But we can look at absorptive capacity. Again, this is liquid, and it's grams per 100 meter square centimeters. So product 1, product 2, again, the leading brands that you see out in the acute care and long-term care settings is compared to the Halyard dressing. And guess what? You have the Halyard dressing, which is comparable and actually a little bit better than product 2. And in terms of retention, better than both of them. And again, at a fair price. So the ideal dressing from our perspective is really focused on adhesion and absorption. But we also want it at a fair price because that's what our administrators want. So that third A is at a fair price. So how can Halyard deliver at a fair price? Well, Halyard's been around for a lot longer than you think. So in 1870, it really started as Kimberly-Clark, and in 2018, it was acquired by Owens & Minor. And as we all know, Owens & Minor has a very wide distribution network. They are distributors. So let's talk a little bit about that Halyard brand. So if you're not familiar with Halyard, you have been familiar with Howard. We went through a pandemic. Most of us probably used a surgical N95 respirator or a mask from them. We certainly use their surgical and exam gloves. So they've been around. They're known for reliability, standardization, and product knowledge and expertise. Again, that third A at a fair price, and that's because of their ability as distributors to be able not to pay a middleman. They don't have to pay somebody to stock their product and then distribute it to you. So because of that, there's better purchasing power with a distributor. And when you look at adding conformability, absorptive capability, silicone peel strength, it's a dressing that works. And really, the best dressing is one that does work. With that, I want to thank you so much for having me today.